What is a midwife? For most of human history, childbirth was a female-led, community-oriented event, and a midwife was typically a local woman who had experienced birth herself and felt a true calling to help other women and pass down this knowledge. There are certified nurse midwives, there are professional midwives or certified professional midwives, and there are certified midwives. All go through a different journey of credentialing, all of whom are safe and evidence-based practitioners who are skilled medical providers, who have the ability to treat hemorrhage, who have the ability to resuscitate a baby and support babies in being safe during labor and birth. And then there are traditional midwives. Traditional midwives are community-based practitioners who support women and birthing families through pregnancy, birth, and postpartum. But rather than going through formal medical schooling, they typically acquire their skills through apprenticeship, practical experience, and cultural traditions passed down through generations. So to really understand what a midwife is, we first have to unpack the history to help us understand why we are today at this place where so many people fear birth and fear midwives, despite the truth that birth is a normal physiologic event that midwives have been supporting for generations after generations. For most of human history, childbirth was this female-led and community-oriented activity. But several hundred years ago, birth really changed. So birth became heavily medicalized because male obstetricians realized that birth was an untapped market. And in order to make the most money off of people giving birth, we have to somehow convince them that their bodies are broken and they need all this stuff outside of themselves in order to give birth. There was a problem though, which is that families tended to really love their midwives and some family doctors who were doing deliveries at home as well. So this problem was known as the midwife problem. The midwives were officially the competition, and that impacted the bottom dollar. Physicians didn't just want to make money off of birth, they wanted to create an empire of bringing everyone into the hospital for birth to make as much money as they possibly could. So in order to do that, they had to launch a campaign against midwives, making midwives seem like they are dirty and they are like not properly trained. And it worked, unfortunately. At this time, it was really hard for the midwives to get together and work to try to fight back against what was going on, because a lot of the midwives were people who are brown-skinned or black. There are midwives who are indigenous to America, midwives who maybe spoke different languages and didn't even know that these other midwives existed, like they didn't really know about each other across the states. And so essentially, because of the lack of a unification between all those midwives, their campaign worked and was very successful. Black grand midwives who were supporting birth in the rural South but came from Africa, they attended births for white women and for black women. And those midwives at one point were actually given licensure to practice, but then their license was removed. Physicians really, really worked hard with lawmakers and with politicians to try to change their hearts and minds and try to explore every single avenue that they could to really reduce the access to midwifery and make it impossible or at least very, very challenging for midwives to practice. And so those black grand midwives, which now we look back as legendary midwives who brought so much tradition and who saved so many lives, they suddenly were facing prosecution, if they wanted to continue to practice. At the same time, there was a physician named Dr. J. Marion Sims, and he performed experiments throughout the 19th century on enslaved black women in Alabama. And so while Sims experimented on about a dozen enslaved women, unfortunately only 3 names were actually recorded in history. There is Anarcha Westcott, who is a 17-year-old girl who endured approximately 30 experimental surgeries without anesthesia over a 4-year period. There is Betsy, an enslaved woman who bore the brunt of these tortures and early procedures alongside Anarcha, and then Lucy, who is an 18-year-old who was the first fistula patient and nearly died from complications like blood poisoning. So I'm teaching you this because when we're looking at what a midwife is, we have to understand, and it's hard to talk about, I feel like emotional talking about it because it's so sad. We have to understand the history of why so many people are afraid of midwives now, and why midwives, though the evidence says that they save lives and improve outcomes for mothers and babies, they still face so many political and social and cultural challenges all throughout the West because of this propaganda, because of this huge movement forcing people into the obstetric system and forcing midwives out of the care system entirely. Another example that I wanted to talk about is Dr. Joseph DeLee. So in 1920, a very influential obstetrician named Dr. Joseph DeLee, he implemented this really popular routine of episiotomies and prophylactic forceps deliveries for all birthing women. So that means no matter what's going on, no matter what your risks are, what medical indications are present or not present, everybody gets a routine episiotomy, which means we're going to do a cut through the perineum. And everyone gets a forceps delivery. Forceps look kind of like salad tongs. They go on the sides of baby's head and they can adjust baby's position and pull out. Forceps now are not used as often, and when they are used, it's normally for when the baby's right about to come out and needs a little bit of support. But back then, forceps were used routinely for everyone, and sometimes they were used when the baby was still up high in the pelvis. And this resulted in severe perineal trauma for mothers and caused infant brain damage and death. So despite this trauma, his methods became really popular all throughout the world, and he even wrote in his medical journal that performing episiotomy and using forceps would restore virginal conditions in women during birth. So this guy was a creep. And he significantly influenced the obstetric system. So I'm illustrating these examples so that we have an understanding of where the obstetric system comes from and what its foundations are. So now let's kind of go a little bit deeper into how we lost all these midwives. So in 1900, 95% of births happened at home. But like I said, obstetricians realized that birth was this untapped market, and today childbirth accounts for 1 in 4 hospital stays. So they were right. We can make a lot of money off of people giving birth. So at the time, male physicians were horrified that women were working as midwives and providing care because in society, they used to believe that women were mentally unfit and incapable of making their own decisions or thinking for themselves. So the OBs launched this coordinated attack, which was to solve that midwife problem, where they said that midwives were dirty and ignorant and dangerous. So now looking back, we can acknowledge kind of where all this comes from and hopefully acknowledge also our own internalized fears around birth and around midwives. Why is it that birth is a normal physiologic event and so many of us are terrified of it? Why? Why is it that evidence shows that midwives save lives and reduce stillbirth rates, reduce preterm birth rates, support mothers in doing well throughout pregnancy and birth and postpartum, have higher rates of breastfeeding success, right? So we're seeing all this evidence. Why are we still terrified of midwives? And that is because of the cultural conditioning that happened. It seems like it was so horrible and so long ago, right? But it really was not that long ago. In the 1900s, that was just 100 years ago. So your great grandmother, potentially experienced some of this or experienced births that were in that system. My husband's grandmother, who recently passed at the age of 94, she experienced all of her births under twilight sleep, where she went to the hospital. They gave her a mix of morphine and scopolamine, and they put her to sleep during her births and did the routine forceps and episiotomy and what have you, right? So that was what she experienced as birth, and she just passed not too long ago. So this really isn't that far behind us. So what I invite all of you to do for the rest of this training is to have an open mind and be willing to learn and see where the conditioning that we see in movies and media, that we see in these really scary stories that we have all been exposed to on one level, was directly created with the purpose to get people to want to take interventions, to get people to be afraid of birth, to eradicate midwives so that hospitals can make money. That is where all of that comes from. So we need to acknowledge where that comes from, and then we also need to have the openness so we can move forward to create a better dynamic with care providers, to create more options and to create safer births for moms and for babies. So Going back into the history a little bit, I wanted to talk about the Black Grand Midwives specifically, and I wanted to honor them by offering some recognition. So despite this really fierce oppression, the legendary Black Grand Midwives brought their knowledge from West Africa to the US, attending the births of both Black and white women all throughout the South. And there were so many of them, but there are 3 specifically that are known to have really changed the course of history. And so one is Margaret Charles Smith. Margaret Charles Smith was an incredible Alabama midwife who famously attended about 3,000 births without ever losing a mother, sometimes walking miles on foot and supporting women through birth without electricity and without water. Then there is Mary Coley, or Miss Mary, who is a renowned Georgia midwife who advocated both for the physical and social well-being of her community. And then there is Gladys Milton, who is a Florida midwife who tirelessly fought to keep community birth accessible despite heavy medical oppression. So midwives are people that have a calling to serve birth, who trust birth, and who want to keep mothers and babies safe. And many midwives and birth workers acknowledge that this isn't just like a career or something that you do to make money, right? A lot of midwives don't make a lot of money. They do it because it's a calling. And that matters because that impacts the way that they show up for that role. So in 2018, there was a midwifery integration study led by Vedam et al. And it mapped out the access of midwives state by state. And the data proves that states with the fewest midwives suffer the highest rates of preterm birth and infant mortality. So it's evidence supported that getting a midwife reduces your risk for miscarriage, it reduces your risk for preterm birth, and it reduces the risk for infant mortality. So in higher integration states like Washington, New Mexico, and Oregon, they have a lot of midwives and they have the highest rates of spontaneous vaginal birth, of vaginal birth after cesarean, and breastfeeding. In the lowest integration stage, which are mostly in the South and the Midwest like North Carolina, Alabama, Mississippi, and Kentucky, they really struggle with those outcomes, and those outcomes are some of the worst. So the percentage of midwife-attended births by numbers in some of those states are Texas 4.4, Louisiana 3%, Mississippi at 2%, and Alabama and Arkansas are tied for the lowest in the country for midwife-supported birth at just 1%. And this has had a really devastating impact on the families in those states. Let's talk about Louisiana specifically. So, in 1915, midwives attended 85% of New Orleans births. Today, due to the hostile regulations, midwives attend just 3% statewide. And so because of this lack of midwifery care, Louisiana suffers a staggering 14% preterm birth rate, which is far above the US average of 9.6%. The maternal mortality rate is 44.8 per 100,000, which is more than double the US average of 20.7 per 100,000. And Black maternal mortality is 73 per 100,000 compared to 27 for white women. Experts estimate that half of these deaths are completely preventable. Now let's go deeper into what the evidence has to say on the models of care, because the reason why midwives improve outcomes is not because they're like have the calling or they like love birth more, like whatever. Midwives have better outcomes specifically because they operate within a different model of care. So your model of care that you're getting is the way you're receiving that care. It's the way your provider approaches care, and it has to do with the provider's philosophy, their standard practices, the way they handle emergencies or challenges, if they look at the whole picture of you, if they look into your history, if they make things more personalized, what they cover in their counsel, right? All of that makes up the model of care. And the model of care that you choose significantly impacts your risk for certain outcomes, like tearing, for example. It's very well researched that obstetricians, just simply being with an obstetrician, is going to increase your likelihood for tearing significantly. But choosing a midwife just in itself is already an evidence-based choice to statistically reduce your risk for tearing. So in the medical model, there's one approach, and in the midwifery model, there's another. And then there is also research on the mixed model. The mixed model is when we have a midwife who is not working independently, getting to have agency in the way that she provides care, but is providing care under supervision and collaboration of physicians or under strict, hospital policies. Some birth centers are not freestanding. So if a birth center is not independent, it's not freestanding, that might mean that it's connected to the hospital or in control of the hospital, or the midwives are supervised by physicians, even though that birth center is separate and in a separate location than the hospital. And so the care we receive there is probably going to be in the mixed model rather than the midwifery model specifically that I'm about to go deep into the research on. So let's talk about the medical model first. The medical model is pathology focused. The medical model treats pregnancy as a high-risk condition, and it treats pregnancy as something that is abnormal until proven otherwise. There is an emphasis on interventions, and there is an emphasis on surgical management. Then there is the midwifery model. The midwifery model treats birth as a normal life event. The midwifery model is holistic and family-centered, meaning instead of just focusing on the physical and the vitals and things like that, midwives look at your nutrition, they look at your family life, your stress, your habits, and support lifestyle and nutrition. And researchers don't know exactly why your risk for stillbirth is so much lower with a midwife in the midwifery model, but it's specified that the counseling around lifestyle changes and nutrition may have something to do with that. So in 2016, there was a Cochrane review that looked at 15 randomized controlled trials and around 18,000 women. And so they found that for preterm birth, midwifery care resulted in a high quality proven 24% reduction in the risk for preterm birth. So a lot of people think like preterm birth, like baby coming early, and miscarriage, those are things that we don't have a lot of control over, and if they happen, they happen. But the truth is there actually are some evidence-supported ways to reduce the risk of preterm birth and reduce the risk of miscarriage, and that is to hire a midwife who operates in the midwifery model of care. And so we've also found specifically with miscarriage and fetal loss that the midwifery model significantly decreases the risk for losing a baby before 24 weeks. Next, let's talk about interventions. So midwifery-led care did lead to fewer episiotomies. It led to less artificial breaking of the waters, fewer epidurals, and fewer instrument-assisted births. Observational data also has something to say on the intact perineum and healing after birth. So hospital midwives, which were midwives who practice in the mixed model, we have some research on them. There was a 2018 study that came out on certified nurse midwives, and they found that the patients who were birthing in that mixed model had an intact perineum rate of 46.4% and an episiotomy rate of just 1.9%, which is very low. A cesarean rate of 17.2%, which is also, that's very evidence-based, and a breastfeeding success at 6 weeks rate of 92%, which is fantastic. We also have more data on out-of-hospital midwives, which are certified professional midwives who support home births. And so this data was from 2004 to 2009, and they found that CPMs achieved rates of intact perineum of 49% across 16,000 home births, and the C-section rate was 5.2%, which is really amazing. So when I talk about intact perineum being with the hospital midwives is 46.4%, the out-of-hospital midwives being 49%, the reason why that's so significant is because in the US, 53 to 79% of moms tear during birth. So 33%-ish do not tear. And so the fact that with midwives, we're seeing it's almost 20% higher is really, really phenomenal. Let's talk next about how midwives support normal physiologic birth compared to physicians who treat birth like an illness needing medical management, and how that can impact your risks, your care, and your experience during birth. So midwives first, they utilize deep traditions and hands-on skills passed down through generations of midwives, specifically designed to support normal physiologic birth. So the midwife has a completely different philosophy and a completely different orientation. Midwives have skills that obstetricians don't. It is false to think that if you go to an obstetrician, they are going to provide you with the absolute best evidence-based care and will cover all the bases because they got more schooling. That's what we think. But they got all this schooling and have all this training for high-risk procedures, for being hands-on, for surgery and things like that. Most births do not need those skills. Most births need skills around how to support the mom in position changes to support optimal positioning, how to relieve tension in the pelvic floor if there's tight tension that's holding things up and preventing the baby from descending, right? How to support the mom in coping with labor well and relaxing and feeling safe, how to support the normal hormones and normal physiology. So I just interviewed Whole Birth and Wellness with Vic. She's on Instagram. You can find her on my podcast. It's called the Peaceful Birth Podcast. And I just interviewed her. She had a twin home birth. And she shared that when she was at the hospital or with different doctors trying to figure out what she wanted her care to look like, they were treating her like she was really high risk, like a high risk condition waiting to happen. And they even asked her if she wanted to keep both of her twins. With a midwife, she found that she was supported in feeling like her experience was a normal and healthy experience. And the midwife was there to support her if something were to come up, right? But she felt so much more safe and comfortable rather than being stressed and afraid all the time. When she was in labor, she had a previous birth and she got a really bad tear. And so there was some scar tissue in the vaginal canal. She was at 1 centimeter the day before, and then she was laboring for a while and was feeling like things are so intense and what's going on, and the midwife checked her and said she was still 1. And she's like, that just doesn't feel right. Like, this is getting so intense. I feel like something's wrong. Then the midwife told her that when she checked her, she felt and assessed that there was some scar tissue inside the vaginal canal from a previous tear. She massaged it and worked on releasing that scar tissue, and she dilated to 9 centimeters almost immediately, and then pushed out her babies not long after that. But in the obstetric model, if we're not looking for those things, we're not trying to support normal birth. We're just letting birth unfold, and then if there's a problem, we fix it, right? And so in this case for her, we're letting birth unfold. Oh, you're just 1 centimeter, it's not changing. Guess it's failure to progress and we give you a C-section, right? So it's very likely she would have had a C-section if she were in the medical model of care, simply because that model is not oriented around supporting normal birth. That model is oriented around checking vitals and then addressing problems. That's what it's oriented around. So I thought that was a really interesting story that I would share. Another story, I have been a student midwife for many years, and after my first was born, I worked at a home birth practice and then a busy birth center. And in the home birth practice, remember there was someone who transferred care to us. I don't know if anyone has experienced listening to their baby's heart rate with a Doppler before, but when you're lying on the table or on a bed, someone puts the Doppler on your belly and they listen, they can hear the placenta, they can also hear the baby's heart rate. The placenta sounds like a whooshy, whoosh, whoosh, whoosh. The baby's heart rate sounds like galloping, ba-bum, 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 ba-bum. And midwives, since they do intermittent monitoring all throughout labor with the Doppler, are often much more skilled with Dopplers. And so there was a mom who came in, she wanted to transfer care after being with an OB for the first and the second trimester. So we're listening to the baby's heart rate and we hear this ba-bum, 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 ba-bum. And she goes, "Is that what my baby's heart rate sounds like?" And we said, "Yeah, that's what it sounds like." And she said, "Oh, like when the OB did it at the office, it always sounds like this whooshy sound." And we put the Doppler over her placenta and we said, "Is this what it sounded like?" And she said, "Yeah." And we said that the OB was listening to the placenta the whole time and not the baby. And that's just because obstetricians are skilled surgeons and they have skills in these categories, right? But in these other things that support normal physiologic birth, like using the Doppler for intermittent monitoring, right? They might not have the same kind of skill around. And so I'm not saying that obstetricians aren't skilled. They are very skilled, but their skill is in a different category. So if you have a midwife here, they cover all these things and they have skills in all these things, but they don't have skills in this world, which is the surgical world, right? If you have an obstetrician, they don't have skill in supporting normal physiologic birth. They don't have skill with breech birth. They don't have nutrition education. They don't know how to support optimal fetal positioning unless they went and got that education independently. But they didn't learn that in medical school. But they have all the skill over here for the surgical stuff, right? And then of course there's some overlap. Both can break the water, both can perform episiotomies, both can address a shoulder dystocia, right? So they have some of that overlap. But there's a big gap in what an OB can provide. And there's also a gap in what midwives can provide. And that is why midwives out of hospital only support moms that are in a low risk category. Midwives are skilled to clinically assess if someone is low risk. And all throughout birth, they continue to assess that someone remains low risk. And if someone exits the low risk category, then they are transferred, right? And that's how midwives practice. And we have found that when there are good community transfer like pathways in place in the communities where midwives can easily transfer care without being yelled at or abused by healthcare staff, where they're respected, where there's community connection and a pathway, that parents are safer. But sometimes it can make it harder for midwives to practice safely when they can't transfer easily because they're facing so much backlash and so much resistance from transferring care. So safer birth is not about restricting midwives or punishing midwives. It's about embracing midwives and finding pathways for all families to be safe and for smooth transfer experiences to happen within the community. And that is the hospital's responsibility. It is the obstetrician's responsibility and the nurses to change their perspective of midwives, to embrace them and to learn how to work with them for the highest benefit of the families in the community and the highest wellness of those families. So because there's a big difference in the core in their training, it can be really devastating for someone who's giving birth who wants a normal physiologic birth to be under the care of a physician who simply lacks the training and the skills to support normal birth. And I put this in here because I think a lot of people say, I'm just gonna learn, I'm going to take classes, I'm going to get ready for birth, and then I'm going to go in there and I'm going to do it. But here's the thing, when you're birthing with a physician, in many ways you are alone. You have someone who can check on your vitals, who can counsel you on interventions, and who can assess if there are emergency things that come up. But no one is going to be supporting you and working through fear in moments where you have fear come up and you don't know what to do. All they can offer you is medicine. No one's going to support you in feeling and facing your own self-doubt and working through it and regulating your nervous system and feeling safe. No one's going to be able to assess your labor from this continuous support. So we're seeing your sounds change, we're seeing your patterns change, and then be able to give you support based on what we're observing. I'm noticing that the pattern isn't really kind of consistently growing and getting longer. They're kind of staying the same, or they're kind of stalling out. Maybe we should try some position changes. You know what I mean? Like this, we're supporting normal birth because we're witnessing and supporting someone. You're getting that with a midwife. We're not getting that with a physician. So in many ways, you're on your own during birth when you have a physician. Midwives provide ongoing support. If you look at the history of birth and of midwifery, midwives were often women who have supported other women in going through that portal of birth and recognize that birth wasn't just a medical event or a physical experience. It was a deeply spiritual experience, an emotional experience, an initiation for an entire family, and that it was sacred. It was a celebration of life. And so we can keep birth safe and also support someone holistically, right? Incorporating compassion and love and connection, personalization, walking someone through that journey of birth with compassion and love, right? That can be in the professional container. The professional container has room for compassion and love. And I truly believe that the best provider you can find for yourself is a provider who loves you, truly, someone who loves you. And that's why, like with my private coaching clients, I say like, love you guys so much, because I love them. I love everyone that I support, because when you're pregnant and you're going through this journey of bringing a life into the world, you deserve to be loved. Through that experience, you deserve love. And many people are going through the experience of birth and also pregnancy and prenatal care in a model of care that doesn't have any room for connection, that doesn't have any room for love or compassion because of the foundation of it. So I'm not saying that physicians are bad people. Physicians are good people that want to do their best and want to help parents have good experiences and safe births, but they're working in a system of care that is fundamentally flawed. The system actually works perfectly. It works the way it's meant to. It works to make money, right? But that's a flaw because it doesn't improve outcomes for people. And it's really hard to work in that system. And I remember being a student midwife at a busy birth center. And when that birth center got really busy, I was seeing 10 people a day and I was exhausted. And I didn't have the capacity to really give to everyone what I wanted to give and give them my energy and attention and celebrating different stages of their pregnancy and milestones. And that's something that they all deserve. And so I have compassion and recognition that physicians are seeing so many people and they just don't have the time to build that connection and to build that joy. And there's so much stress and liability, that they're carrying on their shoulders every single day. So there's not a lot of room for love and compassion and connection in a model of care where there is that much stress. But finding a midwife who works primarily in the midwifery model, so the independent model, that midwife is more independent so they can choose how many clients that they take on. They can choose to be in integrity in the way that they want to practice, and they can choose to bring love into the work that they do. And because midwives often don't make a lot of money, it's very clear that they're not in it for the money, they're in it for the work, because the work is what they're meant to do, right? And so that is a really big fundamental difference that I want everyone to acknowledge when we're comparing a physician to a midwife. Next, let's talk about the difference between postpartum care with a midwife versus an obstetrician. So with an obstetrician, after you have your baby, you'll stay at the hospital for usually a day or two, sometimes longer, depending on if there were complications. And then you're sent home. And then you can take your baby to the pediatrician, and then you can go back to the obstetrician at 6 weeks for a quick check, right, on how you're doing, to sign you off for sex and for exercise. And that's about it. There's no nutrition support. There's no pelvic floor support. There's no hormone balancing support or mental health support. Maybe there's a quick screening on your mental health where you have to tap some buttons to rate how you're feeling. And then they're like, okay, looks good, bye, and that's kind of it. And obviously there are some physicians who are really trying to do more and offer more in those postpartum visits, but there's only so much counsel and education and support we can give someone with one visit. So let me ask you, does it make any sense that you push a baby out of your body that you grew for 9 or 10 months and then you get no care at all except for one visit to say that, yeah, you can start having sex again and exercise? That's absolutely insane. And a large percentage of mothers who die from giving birth happen after the birth. So maternal mortality rates in the United States are very high, and we have very low rates of midwives and not a lot of postpartum care at all. And many of those deaths occur after birth, and many of those deaths are preventable. So there needs to be a really big shift in the way that we support moms after they have their babies. And this is why midwives save lives, because in the midwifery model of care, if you're at a birth center or if you're at a home birth, the midwife will come to your home, and it's a little bit different depending on how each midwife works. But typically they'll return to your home after being with you for a few hours, 3, 4, 5 hours, sometimes more if there were complications after birth. And then they'll return to your home around 24 hours to do the metabolic screen so they can do the test for the baby. They cannot give vaccines, but they can give vitamin K if that's something that you want to do. And many midwives can give erythromycin depending on their credentials. If they can't prescribe erythromycin and that's something you want, then they can work with other providers to help you get that often. And then they can help you with that. So they come at 24 hours to do all the newborn things. And then they're checking on your bleeding, checking on you, and making sure that you're doing okay. And then they come back typically at day 3, and then day 5, and then day 7. Some midwives will come back just at day 5 and day 7. That's what I I've seen, but it varies a little bit, but they do visit you several times in that first week. They see you again at 2 weeks, and then they see you again at 6 weeks. For some midwives, they'll come to your home for all those appointments. For other midwives, they'll maybe come to your home for the first week, and then you go to their office or their birth center for the future ones. So they're checking on the baby, and they're also checking on you. And if anything, like if you go out of their scope, or if your baby has something come up that goes out of their scope, then they would transfer your care. But they do have a scope of practice for the first 6 weeks where they can support baby in their care and their weight and you. Midwives have higher rates of breastfeeding because they give you breastfeeding support. So they can help you ongoing with breastfeeding support, helping you with latching and positioning, give you counsel around sleep, counsel around nutrition. The first time I met my midwife, her name is Margie. I was a birth doula and I walked into the house and the baby came like super fast. So I just missed the birth because the baby came out like 15 minutes after the mom had called me. And this was like 10 years ago, probably. And I walked into the house and there's Margie just washing the dishes. And I was like, hi, like, are you the midwife? And like, that's how I got to know her. She was just there washing the dishes because she's not there just to like do the medical things she needs to do and check the boxes and make money and go home, right? She's there to be of service to that family. And I remember as a student midwife, I've been to, so many people's homes, and we would like do the checks and check on baby. And sometimes we'd hold a mom while she cries. Sometimes we are like helping process different kinds of things that are coming up, right? We're just like really there to give mom support around nutrition, around sleep, around mental health. And then we're taking out her trash on the way out, or even sometimes bringing her a home-cooked meal, right? So this is the difference between community birth and hospital birth. In the community birth, we're part of community. The midwives are participating as members of your community. You're not a person in a system, you're a member of a community. And the way we experience that kind of care is really different. Now let's talk a little bit about what the evidence has to say on the difference between home birth and hospital birth with a midwife. So we don't have randomized control trials where we assign someone to home birth or hospital birth because people don't want to participate in that, right? And that's understandable. So we have our strong preferences around where we want to give birth. So instead, we have to look at studies that are more observational, comparing planned home births with planned hospital births for low risk. So a lot of people say, well, yeah, like if you're in a hospital, you're more likely to get a C-section and more likely for this and that because the high risk people who need those things go to the hospital. And yeah, that's true. So let's just talk about comparing low risk moms in out of hospital and low risk moms in hospital, specifically focusing on home births. So there are a few different studies that I'm going to illustrate right now. One is the US MANA study, the Midwives Alliance of North America, and their stats from 2014. The UK Birthplace Cohort Study from 2011. The Netherlands Nationwide Study from 2009. And then a massive 2018 meta-analysis on place of birth. So what they found was that the benefits of planned home birth for low-risk moms was that they came with lower interventions. So across the board, these studies consistently show that planning a home birth results in drastically fewer medical interventions. The benefits include significantly lower C-section rates, far less use of Pitocin to induce or speed up labor, lower rates of episiotomy and severe tearing, and then higher rates of spontaneous vaginal birth, and number 5, higher rates of successful breastfeeding. And now let's talk about the risks for out of hospital. So for low risk term pregnancies, these studies prove that the perinatal mortality rates, so the risk of infant death, are similar whether you give birth at home or give birth in the hospital. So the takeaway is that for healthy low-risk pregnancies, a planned home birth attended by a qualified midwife is a safe option that protects the birthing person from unnecessary major abdominal surgery and routine hospital interventions. Okay, also I wanted to talk a little bit about how midwives show up for home births and also what you see at a birth center birth, because I think a lot of people think that midwives just show up with like sage or something and like feathers and they like are these like spiritual hippie. It's not true. Midwives are licensed healthcare providers and healthcare professionals. So they bring hemorrhage medications, they can administer IVs. Certified nurse midwives have access to prescriptions or have prescriptions abilities, so they can prescribe antibiotics if needed, and other medications. Many midwives carry epinephrine on the rare circumstance that a baby would need that to save their life during resuscitation. Midwives can intubate a baby. They can do neonatal resuscitation. Midwives can also incorporate different strategies to really reduce the risk of even needing some of these medications, right? Like, for example, a really, really long labor does increase the likelihood for having a hemorrhage because your uterus can get so tired. And long labors often happen when we are struggling with a lot of positioning challenges. Midwives can support position, and that can maybe help, right? Reduce the risk for hemorrhage. That's just like one example. So let's talk a little bit now about the legacy of racism and modern health disparities and how midwives can be a resolution for this. So I want to talk about educational segregation and Mary Breckinridge specifically. So Mary Breckinridge founded Frontier Nursing Service, and that was one of the largest nurse midwifery schools in the country. And she actively denounced the local Black grand midwives to elevate her own white professionals. So she did not admit a single Black student to her school until after she died in 1965. So current demographics from a 2019 AMCB report shows that because of this deeply rooted segregation, the midwifery workforce today is overwhelmingly white. So white midwives make up 87% of the workforce. Black midwives make up 6.3% of the workforce. Indigenous midwives and other minorities combined make up less than 10% of the workforce. So this is due to a lack of leadership, representation, and to many other systematic strategies. Currently, out of 39 graduate programs in the US that train certified midwives and nurse midwives, only 2 have Black program directors. So there was a mistreatment study in 2010 to 2016 with about 2,000 birthing people. 1 in every 6 experienced some kind of mistreatment when they were giving birth. That's 17%. Indigenous, Hispanic, and Black women were twice as likely to be ignored, scolded, or shouted out by providers. And we found through research that the setting matters. So for women of color, mistreatment rates were 34% in hospitals and just 6.6% in community birth settings with midwives. So this is why I mentioned before, and I'll say it again, people have better experiences with midwives, and midwives save lives. Because right now, women of color are 3 times more likely to die from childbirth, and midwives are a solution to this problem. So what can we do, right, to help make the world a better place? And what can you do to help make your birth a better experience? I recommend that everyone explore and see if they can find and access a midwife in your community. A midwife is one of the best investments that you can make. And unfortunately, every state is different in the US when it comes to midwives. In Canada and in other countries around the world, there's also a really big difference in the way midwives practice and operate and the different rules that they have to follow. So there isn't one universal way. It really depends on where you live and where you have what the kinds of midwives you have access to. This world needs many, many more midwives to solve many of the problems that we're facing, specifically problems around infant and maternal mortality and racism in medicine. And so you may be in a maternity healthcare desert, which is a place where there is not a lot of access to many kinds of different options for maternity care. So maybe there's one hospital an hour away from you and that's it. Right? So what do we do when we're in that situation? And it's really up to you. Some people will do whatever they can to get a midwife, meaning they might have to temporarily relocate. They might have to move in with their parents somewhere, right? Maybe it's a place where they have midwives. They might have to fundraise to be able to access a midwife. But still, this is something that people who have a job and have a life and don't have more extra income to spend on midwives aren't able to access. And so bringing in more midwives to more communities is absolutely essential, and getting the ability for midwives to bill insurance is also essential. In many places, midwives, you have to pay out of pocket. There are some states like mine in Oregon where midwives are covered. My midwives were covered in all 3 of my births, and it was just the most amazing gift ever. That's something that a lot of people don't have access to, unfortunately. So I want to just offer an acknowledgement that midwives are the best. And it is so worth exploring to see if you can access a midwife. And it's also a true reality for many people that midwives are very challenging to access. So we need to then make choices for our birth that feel really best for us. Can you access a hospital with midwives instead of a home birth or a birth center birth with midwives? That will be a lot better for you if you're wanting to be in that philosophy of care and in that model of care. It will be in the mixed model, but that mixed model still comes with many, many benefits, right? Also getting independent education, so you learn how to navigate a hospital system or even work with physicians in a way that supports you in having a more positive experience, because you really understand advocacy, you understand your options, and you're really independently educating yourself. You can still have great experiences with physicians. But if you can access a midwife, I recommend exploring that. If you are like, I'm too high risk, someone told me I'm 38 and that means I'm too high risk, or I have gestational diabetes, that means I'm too high risk, I invite you to just explore the stories that you've been told about high risk and have an openness to see that maybe you aren't as high risk as you think that you are, just so that you can talk with a midwife and get another opinion. Because some people think I'm high risk, so they just kind of shut down that possibility for them. But in many cases, like with my friend who had twins, for example, I'm remembering it now, it's whole birth wellness with Vic. I'm pretty sure that's her Instagram. She's so great. She said that it was with her OB, she was high risk. With her midwife, she wasn't high risk, like her midwife didn't treat her like she was high risk, and she could access a midwife, but the physician was really trying to get her to not do the home birth, because they thought she was too high risk. So every person is different and has a different opinion. So it's important to acknowledge that you can always get another opinion. And it's worth asking and exploring the midwives in your area and just seeing if you would be a good fit to work with them, and explore what it costs, explore if they offer payment plans, see if you can fundraise, see if you can save up for your next birth, right, to have a midwife. The bottom line is that home birth is a safe and evidence-based choice. So based on massive gold standard research like the 2014 US Manus stats, the 2011 UK birthplace cohort, the 2009 Netherlands study, planning a home birth is a safe and evidence-based choice for full-term pregnancies that are low risk. So these studies prove that low-risk individuals who choose home birth experience similar infant safety outcomes, which is called perinatal mortality, as hospital births, but are protected from the cascade of routine interventions, unnecessary major abdominal surgery, and severe tearing. Next, let's talk about the bottom line for state-by-state impact. So what we're seeing here is that more midwives equal better outcomes. When we look at the mapping data, states that highly integrate midwives make community birth accessible, like Washington, New Mexico, and Oregon, see massive statewide health benefits compared to heavily restricted states. The statistical benefit of having more midwives in a state include higher rates of spontaneous vaginal birth, higher rates of successful VBACs, higher rates of breastfeeding initiation and success, significantly lower rates of preterm birth, lower overall rates of infant mortality, and a reduction in racial health disparities. So how do midwives actually save lives? They prevent premature birth, right? The midwifery-led model is scientifically proven to reduce the risk of preterm birth by 24%. They protect early pregnancies. Midwifery care significantly lowers the risk of miscarriage and fetal loss before 24 weeks, likely due to their holistic nutritional and emotional support. They reduce surgical complications. So by keeping C-section rates down to like 5%, they save women from severe risks from major abdominal surgery like hemorrhage, blood clots, and future placental complications. Also, they mitigate racism and medical mistreatment. So for Black, Indigenous, and Hispanic women, the hospital medical model carries a 34% mistreatment rate. Midwives in community settings drop that rate to 6.6%, directly protecting marginalized women from the medical neglect and chronic stress that lead to preventable maternal deaths. And now let's do a quick summary of those 3 different models of care. So, right, we talked about the independent midwifery model of care that focuses on treating birth as a normal physiologic life event. The midwife is the lead professional, And this statistically benefits us by having the highest chance of intact perineum, around 49%, the lowest chance of C-section, around 5.2%, the lowest risk of experiencing medical mistreatment, especially for women of color, higher rates of parent satisfaction, so feeling proud, in control, physically and emotionally supported. And then the statistical drawbacks or risks involve, based on the studies we have, slightly longer labors as midwives don't rush physiology, an 11% chance of needing a maternal transfer to the hospital, and most commonly for prolonged labor or the desire for pain relief, and a 1% chance of needing a newborn hospital transfer. In the mixed or shared model, which is hospital-based nurse midwifery, the focus specifically is for midwives to provide care, but they're supervised by obstetricians or operate within a hospital's medical hierarchy and protocols. They're statistically likely to have these benefits, which would be a lower rate of C-section compared to doctors, around 17.2%, very low episiotomy rates, 1.9%, high VBAC success rates, 78.6%, and a high likelihood of intact perineum, 46.4%. So the statistical risks include still subject to the hospital environment, meaning there are higher rates of interventions like Pitocin, breaking the water compared to a home birth. There's a higher risk of experiencing hospital-based mistreatment or feeling rushed by medical protocols. And then the last model of care is the obstetric or medical model, where the focus is pathology focused. Physicians act as professionals, treating labor as a high-risk procedure, right? A medical procedure until proven otherwise. And care emphasizes active management and intervening. So the benefits include immediate access to highly trained surgeons, operating rooms, and NICUs if a severe high-risk medical complication actually arises. And that's why it's important for high-risk people to be in high-risk settings. With midwives are trained and also have to follow certain rules to keep their license, to monitor and risk assess throughout labor. We think of like something bad happens and like, what if you weren't in the hospital, right? Like if you weren't in the hospital, you would have died. Like a lot of people talk about that. But why was that person in that situation the first time? Because in many cases, there suddenly became an issue with baby because we were giving the mom Pitocin, and we gave the mom more Pitocin and more Pitocin and more Pitocin, and we didn't turn it off, even though research and evidence says it's beneficial to turn the Pitocin down or off right once we get to the desired effect of active labor. But in many hospitals, we keep giving it to you. So if we keep giving it and giving it and giving it, and then you get to a point where your baby gets stressed out and then we need a C-section. Oh my God, thank God you were in the hospital, right? Your baby got stressed, and if you weren't in the hospital, your baby would have died. But that problem was caused by interventions. With a midwife who knows how to support normal physiologic birth, and if you don't have medications in your system, the risk of something suddenly happening like that is very low. And if something does start to not look good, then a midwife will transfer before it becomes a big problem. So there are statistically more likely, or like the drawbacks of an obstetrician include a higher likelihood of receiving major interventions like epidurals, Pitocin, or instrument-assisted delivery, a higher risk of having your water artificially broken or receiving an episiotomy, a higher risk of premature birth and early fetal loss compared to the midwifery model, and higher rates of feeling mistreated, ignored, or scolded by providers, with a 34% mistreatment rate for women of color. So the way to solve many of the problems that we face is to hire a midwife, is to expand midwifery, is to give Black and Indigenous women access to midwifery training so that we can directly support giving all the people better access and options to midwives so that moms and babies can have better experiences and can have better outcomes as well. In many countries all around the world where midwives are the primary care providers. So when you're pregnant, you go to see a midwife. And if for some reason you enter a high risk category, then you go and see an obstetrician. Obstetricians oversee the high risk people because that is what they were trained to do. Midwives oversee the low risk people because that is how they are trained, and their outcomes are so much better. The maternal mortality rates, are so much lower compared to the United States, where there are really high rates of maternal mortality and really high rates of obstetricians and very low access to midwives. So this is something that isn't going to be changed tomorrow, but all of us can participate in supporting destigmatizing midwives by speaking positively about them, by informing our friends, our pregnant friends, that midwives are an option, telling them about midwives, right? And just being part of the conversation and looking into a midwife for your care as well. And mothers and babies are the most precious beings, right, in the community. Obviously, like, we love the men and we need the men too, but there are only two kinds of people in this world. There are mothers and there are the mothers' children. If the mothers are supported, the mothers feel safe, if the babies are healthier because the mothers are healthier, that is how we change the whole world. There are so many problems and this world feels like a really scary place, and I really believe that directly supporting the mothers and the babies is the solution, and that starts with you in your pregnancy, showing up for yourself, supporting yourself, investing in yourself so that you can have a happier, healthier, better birth and postpartum, so that you can be a happier, healthier person and you can raise your children to be happier and healthier people. And that is how we change the generations to come.